Hey guys, welcome back to my channel. I am Muriel. This is As Told by Muriel, and on today's video I just came to talk to y'all about an experience I just had working at this facility. It is a facility that I worked prior to, and I know sometimes I get on here, I talk about agency nurses and I kind of make it seem like it's all lollipops and roses, y'all, but this is to give y'all an example of one of the most horrible days I've had at work, working at a facility through agency. And I'll let y'all know why I decided to take this shift, so stay tuned. Okay guys, so there's this facility here in the city that I live in. I have worked prior, I've gone through there through a couple different agencies, and this facility is I almost call it a multi-purpose facility because they have different levels of care there. They have an independent living / assisted living, have another skilled living part, they have another that's like rehab and long-term care, which these rooms are private rooms. And so the rehab / long-term care unit, I've worked there a couple times on day shift, and I vowed to never go back there again on day shift. If you've ever worked on a rehab unit, you know most rehab patients, they're straight out of the hospital. They you know, they're kind of used to a certain level of care in the hospital, and then they come to this unit and it's rehab, and they're expecting, I think in their mind, they're expecting a certain level of care, but then they, and being that it's new to them, they kind of, you know, it's almost like they think they're at the Hilton, Four Seasons, you know, a nice sandals resort or something. And a lot of them come in there and they are not really fully recovered from whatever they had acutely going on while they were in the hospital. So this agency put out some shifts. They were like they were short shifts, like 4-hour shifts, but they were going to pay an extra 4 hours for the shift. So this facility happened to be paying $39 an hour. Well, through the agency, it was $39 an hour, and they were looking for someone to do a 1 to 7 or a 2:30 to 7 shift, and you get paid an extra 4 hours. So when I broke that down, that's basically 4 hours of work. Yeah, 4 hours of work, because you should have got a 30-minute break at $39 an hour, but really you're getting like $78 an hour. That's the way I look at it. So even though this facility is one of those facilities, this particular floor was the floor I said I would never work again, day shift. I was like, $78 an hour, I can grin and bear it for 4 hours. So y'all get to the facility. As soon as I'm walking through the door getting checked in, I notice there's an ambulance bringing a patient in at the very same, you know, the very time that I'm walking in. And in my mind, because I am working this particular floor is the rehab floor. Oh, excuse me, y'all. So I'm like, Lord, please don't let this be an admission for me. Please don't let this be an admission for me. So of course, y'all, it's an admission, and it's on the wing that I'm working. So 2:30 p.m. I'm getting off at 7. Already got an admission coming in, which was actually a readmission. But y'all, readmission and admission is almost basically the same thing, because there's the same, you have to do the same assessment. So okay, I'm like, okay, so this is my readmission. Okay, so I get report from the off-going nurse. He tells me, you know, this and this is good, this is good, this is how they take their meds, blah blah blah. You know, there's this one dressing I wasn't able to get to today, and I was like, oh, no problem, I'll go ahead, I'll do it. It was a simple abdominal dressing or whatever. So I went ahead and got report from him, got the keys or whatever. So as soon as I come on shift, what I like to do is I don't always make walking rounds with the nurse. That is good practice to do a walking round with the off-going nurse. But I just peek my head into each individual room and I introduce myself to the resident. So I went through each individual room, you know, hey, how you doing? Your nurse until 7 p.m. I always like to let them know what time I'm leaving. I'll be your nurse until 7 p.m. I just wanted to lay my eyes on you, make sure everything was okay. Okay, so I do that. As soon as I get back to the desk, the doctor's up there. Hey, can I get a set of vitals on so-and-so and so? Oh, okay, no problem. So, I could have delegated this to the aides. Now, unbeknownst to me, the aides had already gotten all the vital signs on the patients, but I went ahead and I grabbed them anyway and, gave it to the doctor because he needed it on that readmission or whatever. So I gave that to him. Okay, so now I'm looking through my medication list to see who gets what at what time or whatever, so I can prepare myself. Okay, this person's blood sugar, blah, 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 all that. I look at that. Then I go quickly, because my thing is, I'm here only for 4 hours. I went ahead and I pulled everything that was needed to do this abdominal dressing on the patient. So I went ahead and did that wound care on that patient. Okay, got that out of the way. Now, as I'm passing medication, like I said, you can be on the cart, and if anything's going on, people will come and interrupt you throughout the shift, throughout that while you're on the cart, and tell you whatever. So y'all, these patients, I'll go in, I give them their medication or whatever. We have to do a pain assessment on everyone. So I ask everybody, hey, how you doing? Are you having any pain right now? A lot of people are like, no. Some people went ahead. Rehab patients tend to ask for their pain medicine when they need it, like when they're in pain. Sometimes it's before the time that they can get it. And by the time I started passing medication, I had already administered 2 PRN pain medications to 2 patients. Okay, so I'm asking, and then by the way, I think I had a total of 21 patients. All right, and some people were saying yes, some people were saying no. And a lot of them had their family members in there, like sitting in the room with them, which is now that I see, even though the numbers are surging, they're still allowing family members to visit and sit in the rooms and visit with patients or whatever. So, the family members always have their little part that they want to add to whatever. So, anywho, I'm fine with that. But so I got to this one particular patient's room, and I was like, hey, are you having any pain? She was like, yeah, my blah, blah, blah is hurting or whatever. It's been going on for a little while. So and then the family was like, well, she did have a fall. And I was like, oh, okay, well, I said, well, where is it hurting? And she was, pointing at her buttocks, and I don't like to use medical terms with patients. So, because a lot of them, you say sacrum, they're not going to know what you're talking about. You say coccyx, they're not going to know what you're talking about. So I was like, oh, it's bad. Okay, well, let me take a look at it. But I look at the area, and this patient has a hole, the top layer of skin is basically sheared off in between her gluteal fold, which is in between her buttocks. There's a shear of skin that is missing. So I'm like, oh my goodness, why? Now, mind you, this patient didn't just come like the day before or whatever. This patient has been here for about 2 weeks. So I'm like, oh, okay. So it's not, and I'm explaining to the family, okay, so it's not like she has any bony prominence or any area of, any of her skeleton is not like poking where it's being uncomfortable for her. She actually has a layer of skin that's kind of sheared off, something like an abrasion in between her buttocks. And I was like, that's an odd place to get an abrasion. But, I'm going to go ahead and handle it, because anytime she urinates or whatever, I can see that being very painful. And so as nurses, we actually have to get orders from the doctor, but just my nursing judgment, I knew right off the bat that something needs to go on there. Something needs to be, something needs to be there. And this woman had no barrier cream, no nothing on her. So I applied some very, 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 very thick barrier cream. And if you don't know, if you're a nurse, once you discover something on a person's body, you have to do a full body audit on them at that point. So I'm like, okay, well, let me go ahead. So I went ahead, while I was looking, I went ahead and did a full body audit on her. Didn't see any other areas. Got some barrier cream, put it on the area, and I explained to her that your pain is coming from, you have a little shear, like an abrasion in between your buttocks, and that's whenever you urinate or anything, it's going to be very painful. So I'm going to, put an order in that they continue to apply this cream to your area. But of course, y'all, before I put the order in, I'm going to notify the doctor or whatever. But to be honest with y'all, I went ahead and put the cream on there, and then I called the doctor afterwards. I called the doctor after I did my round, I probably shouldn't have done that, but something had to be done because I couldn't drop everything right then and call the doctor because I had medications that were going to be late. I had blood sugars I had to do before they eat, and it was almost meal time or whatever. So I went ahead and put that layer of cream on her. Now, as I'm going, doing the rest of my, passing my medication, one of the aides come to me and she was like, hey, patient in room number blah, blah, blah is complaining of pain on her bottom. And I was like, oh, and the aide was like, yeah, I told a nurse about this a couple days ago, and she went and looked and she didn't see anything there. So I was like, oh, okay, well, when I get to her, I'll take a look at it. Now, mind you, before I got to her, I had a blood sugar that was 473. The patient, had already had a scheduled or dose of regular insulin, but anything over 400, we had to call the doctor. So now this is something I need to call the doctor before, because it was before he even ate, his blood sugar was 473. Okay, so now two things I need to inform the doctor of. So now I get to this patient's room that had a complaint, and I turn her over, and she has a big old broil, I think we call it, on her buttocks, y'all. It's about this big around. It is hard. It is draining. There's no way that could be missed. So I tell her, I was like, okay. And I'm touching. I'm like, is there, ow. Oh, I said, ma'am, you got a big old boil on your bottom. I see why it's very painful. I need you, if possible, if you could stay turned to your side. And I'm going to go ahead and I'm going to get a foam dressing. I'm going to clean it up and I'm going to put it on here because it is draining. And she was like, I knew it was something back there. I tried to tell them it was something back there and nobody would listen to me. And I've been in pain for 4 days. Y'all, I immediately got pissed off. Why? Nurses, why? I'm here for 4 hours. I'm here from 2:30 to 7, y'all. Why? I can't just ignore these things. And in my mind, I'm like, okay, a nurse, look, it's no way a nurse could have missed this. It's no way. She could have said there was nothing there. This thing is to the point, y'all, I think this thing needs some, I think the patient probably needs some antibiotics. So now I had to call the doctor, and that's the third thing I had to notify the doctor. As I'm continuing to pass meds, mind you, I went ahead and cleaned it and put a foam dressing on it or whatever because it's draining. It's actually almost like, I'm not gonna say pus, but it's draining. It's blood tinged drainage coming from that boil. So then I'm going to the next patient. This person has to have a bladder scan done. Oh my goodness. It should have been done earlier that morning. The nurse that left didn't do it. So now I got to do a bladder scan. So y'all, mind y'all, now it's about 6 o'clock now. Did the bladder scan. Bladder scan is not working properly. Bladder scan saying the person got 0 mLs in their bladder. Now, mind you, I had to get the patient to void first before I did the scan. That was the order, to get them to void. So I got her to void. She actually was running like a stream, y'all. One thing I do for patients, and that because it works for me, is I let the water run a little so they can hear the water. It kind of helps you pee. If you're having difficulty peeing, and I think that's the thing with her. They're thinking she's retaining urine. So she was going. She peed she peed, and then she stopped, and then a stream started again. She did good. But then as I was doing a bladder scan, I was like, this is strange. No one has 0 mLs of urine in their bladder. And she was like, I don't understand why he's saying that, and I feel like I have to pee. I feel like I still have to pee, and I was like, yeah, this is strange. I don't know what's going on with this bladder scan. And then I said, well, if you feel like you need to pee, let's get up. So we got up. I helped her back to the bathroom. Y'all, she started peeing again. So I'm like, oh my goodness. The order was for me to in and out cath her if the bladder scan shows anything above 300 mLs. Well, of course, the bladder scan is showing 0 because there is nothing, the bladder scan isn't working properly. So anyway, the fact that she peed 3 times, I was kind of like, okay, well, she said she hasn't had an in and out cath since she's been there. But the order has been there for the bladder scan since she's been there, because when she was actually at the hospital, she had ascites, which is fluid in the abdomen, and the daughter was there. The daughter was at the facility, and the daughter told me they drained off. I think the daughter said they drained off about 1 liter or 2 liters of fluid out of her stomach. And so I was like, oh goodness. I don't want to in and out cap this woman because I really don't know how much urine is in her bladder because the bladder scan is not working properly. She did basically have a good stream of urine 3 times on me. She obviously is retaining though, because after we did the scan, she got, you know, after she urinated twice, went laid down, got back up, took her to the bathroom, she urinated again. But I was like, oh, I kind of I was to the point where I really didn't know what to do, y'all. I really didn't know what to do. So this is something I had notified the doctor about as well. So now it's 6 o'clock. I'm supposed to get off in an hour. Hadn't even done anything for the admission that came in. I mean, I did this, like I did her body audit. I looked at her oral cavity, looked at her teeth, did all that, asked her questions about pain and all that. But I hadn't put any of this in the note. So now I got to call the doctor. The person's blood sugar was 473. They had begun to eat, and I hadn't given them any additional coverage or anything because I hadn't called it out. So I called the doctor. The doctor orders, 10 units of insulin for that patient now and recheck, do a HS blood sugar. Okay, did that. States for the patient with the boil. Didn't give me any orders for antibiotics, but did say it's up to them. I can do warm compresses, or if the patient feel like if the pain is intolerable, I can go ahead and send them out to the ER to have it lanced. And so I posed this to the patient, and I was, the patient, this was a Friday, patient was getting discharged Monday. I was like, I can send you to the ER now. If the pain is intolerable, I can try to warm compresses, or when you get discharged on Monday, if you can, if you want to go to the ER yourself or to a non-emergency clinic and have it lanced, you can do that as well. So the patient chose just, take the pain medication for me to do the warm compress, which was really at a very weird place to really do a warm compress. But anywho, that's what we did for that patient. So, mind you, I have to document all this stuff. So on top of the documentation I gotta do for the new admission, I gotta document all this stuff, like the high blood sugar, the boil on their buttocks, the patient that had their abrasion in between their gluteal fold. Like, I have to document all this stuff because y'all know I say all the time, if it's not documented, it wasn't done. So now I sit down to document all this stuff, to put the assessments into the, y'all, I didn't leave that facility till like 8:45 that night. I was so upset. In my mind, I'm thinking, quick 4 hours, I can do this. But it ended up being, I got there at 2:30. I left there like 8:45. So 6 hours and 15 minutes. Mind you, I'm still getting paid an extra 4 hours, but still, that wasn't my intention to stay there that long. So I just did this video to let some of y'all know that this is the type of stuff that you encounter when you're going through through a facility as an agency nurse. It's just, I didn't come, I came to be a nurse, but y'all, I didn't come for this. I didn't come for that. I didn't come for that. I came to pass medication. I came to, pass medication, do blood sugars, and I came to leave. Because I could have been one of those nurses that was like, oh, well, I'm only here for 4 hours. I could have been one of those nurses, but then I thought about the fact that a lot of these situations I had that was going on had been going on. So that means the nurses prior to me didn't address them. And that means the nurses after me probably wouldn't address them, because this facility utilizes a lot of agency, and a lot of agencies had that train of thought that, well, this ain't how, I'm not about to, a lot of agency nurses had that train of thought. But I don't like to be one of those agency nurses, and it may be to the detriment of me, but I really care about the care of my patients, and I try to do things and follow through on them. If I can, I try to do things and follow through on them. Now, as far as that admission, the only thing I was able to get done was the body audit, the pain assessment, and the admission profile. I was able to get those done. Every other assessment, I would have been there till about 10 o'clock that night had I been trying to finish all those assessments, because a true admission on a patient, a full admission on a patient, especially in a facility that you're not used to, could take up to like 2 hours to complete. And I wasn't about to do all that. And you have 24 hours to complete an admission on a patient, and it's not just for the nurse that the patient came in on. I came in at 2:30. The patient came in at 2:30. I was supposed to leave at 7. I let the nurse that was relieving me know what I was able to do, and it's up to the rest of them to get the rest of it done, y'all. But anyway, I just want to give y'all an example, like I said, of the type of things that can go on when you're an agency nurse and you just walking into just a mess. And you got to make that choice. Am I going to be this type of nurse today, or am I going to be that type of nurse today? You know. But anyway, I will catch you guys later. If you like this content, hit the subscribe button, like my video, share my video. I've been told by someone, and I really appreciate it, y'all, because I'm not gonna lie to you, every time I make a video, I be thinking this gonna be my last video. I ain't making no more. Like, it's like I be like, this gonna be my last video. I think I put enough information out there. I'm not making no more. But then I get somebody that say, you know, somebody actually on Facebook, one of my Facebook friends, who told me, I watch your videos, they are so helpful, and I have other nurses watching them, and they say that, you know, what you are saying is true. And I told them that I kind of made this for kind of like for nurses who are not seasoned nurses. I kind of made this for newer nurses coming out of school who are my age, you know, because a lot of mature women age-wise are apprehensive about going into a new field or whatever. They think they're too old to do it, and I just don't want anybody to think they're too old. You're never too old to learn, and that's what you're going to be doing, learning. You're never too old to switch careers as long as you're physically able to do so. And then he was like, no, some of the stuff you're saying, they didn't even know about that stuff. You know, they were shocked to learn some of the stuff that you were saying. And I was like, for real? Wow, I thought everybody who's been a nurse knew these things. So anyway, that's all. Just goes to say that it's my subscribers and the people who watch my videos that encourage me to keep the content coming. Because every time I do a video, I'll be like, I ain't making another one. You know, but y'all keep me going. So I want to say I appreciate y'all. Thank you for watching, and I will see you on the next video. Bye.